So this, good evening, everyone, and warm welcome to all of you joining us today from all over the world. My name is Dr. Zaina Al-Mahairi, and I am the leader of IVPN Personalized Medicine. I'm also an assistant professor of genetics at the College of Health Sciences at Abu Dhabi University, and have spent the last several years focused on advancing pharmacogenomics education, research, and implementation, particularly in this region of the world. I'm truly delighted to have you with us today for what promises to be a rich and practical discussion. Let me take a moment to remind you of the mission that brings us together under the IVPN umbrella. IVPN and Personalized Medicine is a growing educational initiative and professional network that through this network, we aim to promote awareness and understanding of pharmacogenomics and precision medicine, build educational opportunities that serve both students and practicing professionals, and encourage cross-border collaboration, especially among communities across the Middle East and beyond, and most importantly, to bridge the gap between research, education, and real-world clinical practice. So actually, over the past year, we have hosted webinars, launched collaborative efforts, and connected professionals from around the world who are passionate about the future of personalized medicine. And today's event, entitled From Insight to Impact, Real-World Pharmacogenomic Implementation Models, is another step in that journey. We are excited to hear from the speakers who are not only leaders in the field, but also who are actually applying pharmacogenomics in their clinical settings, facing challenges and reaping the benefits firsthand. Before we begin, I'd like to introduce our moderator for today's session, Dr. Sharmeen Roy, who will guide this discussion and help us reflect on the takeaways. Dr. Sharmeen Roy is the Chief Strategy and Science Officer at DOSME, where she leads the integration of model-informed precision dosing into clinical care. With over 2 decades of experience spanning pediatric pharmacy, pharmacogenomics, and clinical innovation across leading healthcare systems, Dr. Roy is committed to making precision medicine more accessible and impactful across diverse care settings. So thank you again all for being here. We are looking forward to your engagement, your questions, and your continued contributions to this growing field. And as a quick note, certificates of attendance will be shared with all participants within the next 1 or 2 weeks who attend this session. And with that said, I will hand it over to Dr. Sharmeen Roy.
Thank you, Dr. Zaina. Good evening, everyone, or afternoon, depending on where you're joining from, but a warm welcome for today's IVPN Personalized Medicine webinar. As we stated, the title of the webinar today is From Insight to Impact, Real-World Pharmacogenomics Implementation Models. It's really a privilege to help guide this important conversation on the practical realities of implementing pharmacogenomics in diverse clinical settings. And we're very fortunate to be joined by 2 outstanding speakers who bring both expertise and firsthand experience to this topic. First, I'm really delighted to introduce to you Dr. Sarah Rogers, who's a friend and a colleague. She is a clinical pharmacologist and a faculty member at Texas A&M University College of Medicine, where she holds joint appointments in translational medical sciences and engineering medicine. She leads precision medicine initiatives at Texas A&M Health, where she directs a pharmacogenomic clinic focused on optimizing medication therapy for complex patients. But that's not all. Dr. Rogers is also a co-founder of the American Society of Pharmacovigilance and helped establish the STRIPE Collaborative Community, which is a public-private partnership developing standards for pharmacogenetic testing. And I've had the pleasure of being part of that community and participating in many of the initiatives that she's put forth. She currently serves as also the chair of the U.S. Pharmacopeia Personalized Medicine Expert Committee for the 25 to 2030 cycle. Her work spans clinical innovation, research, and education, all driven by a deep commitment to equitable access to personalized medicine. But that's not all. Following Dr. Rogers, we'll hear from Dr. Badr Al-Ghamdi. He's a leader in clinical pharmacy practice in the Kingdom of Saudi Arabia. He is actively participating pharmacogenomics and behavioral health settings and has helped design a clinical workflow model tailored to this population. He's also a mentee of Dr. Rogers and brings a valuable real-world perspective on the implementation and collaboration. We will conclude the webinar with a discussion and Q&A session, so please feel free to submit your questions in the chat box, and we'll keep track of that and try to answer all your questions at the end of the webinar. And with that, let's begin with Dr. Rogers. The floor is all yours.
Great. Thank you so much, Dr. Roy. It's an honor to be here. And today I'm just going to talk a little bit about what's the vision and then how we've tried to implement some of the vision in practice. And it's very much an iterative process. So look forward to your questions and comments as well. I have kind of a unique journey. I got my start in oncology at MD Anderson Cancer Center. 2018, I left. I started ASP just in realizing what a big problem adverse drug events are. And in 2021, that's when I came to Texas A&M to roll out our clinical pharmacogenomics pilot, where I do teaching, clinical practice, and research. So in all of these different efforts that I've worked with both Dr. Roy and Dr. Al-Ghamdi, as well as in the others on, we're really just interested in advancing precision medicine. And simply that's finding the right drug for the right patient at the right time. And also how we can leverage data, including relevant genetics data, to navigate the different treatment options and identify in the first place what the right medication is for that specific patient in the first place. So that's kind of at the root of everything that we do. Okay, so I thought we could kick it off with a quick question. It's gonna be, you can either scan this QR code or type in the website polev.com/srogers. And let me activate it really quick. So the question is, how would you describe your knowledge pertaining to the role of pharmacogenomics and medication management? So can you confidently explain this topic? Do you feel that you have a good understanding of the topic? Have you heard of it but don't know the details? Or do you have no knowledge of this topic? And I'll give everyone a minute to add in their responses here. All right, I think we have a pretty good spread. I think as expected with this being kind of the personalized medicine group at the IVPM. About a third can confidently explain, a third have a good understanding, and then some folks have heard of it but don't know the details. So we'll talk a little bit about some of the background and then what we've been doing in the clinic as well. Okay, so pharmacovigilance, and Dr. Roy mentioned we co-founded the American Society of Pharmacovigilance, but that's really just any effort to identify, track, monitor, or prevent an adverse drug event. And this quote here on the screen speaks a little bit to the problem, and it's simply that the number of adverse events is trending dramatically upward, 10 to 20% increases in adverse event reports every year, a number that's not going anywhere from but up. And that was a quote from the head of global patient safety at Eli Lilly about 6 years ago, and the trend continues. Here in the US, we have some data showing that we spend more than $500 million in avoidable costs every year. Adverse drug events are a leading cause of death, and really around the world, this is a public health emergency. So this figure is taken and it's adapted from the National Action Plan for Adverse Drug Event Prevention. And it shows us a little bit about how some of these different terms that we use a lot in healthcare can play into the larger issue. And it's just really important to kind of understand the terminology. So I wanted to put it here as kind of a refresher. And sometimes these terms are used interchangeably, but it's not always accurate to use them interchangeably. So you have medication errors, which is the inappropriate use of a drug that may or may not result in harm. So you can see in the figure that a lot of medication errors occur every single day, but not all of them result in harm to the patient. So for example, maybe the patient was supposed to get 500 milligrams of Tylenol, but they got 750 instead. That was a mistake. It was an error, but it may not result in harm to the patient. So it didn't create an adverse drug event, which is any injury resulting from a medical intervention related to a drug. Adverse drug events can include overdoses, allergic reactions, and adverse drug reactions, which is the largest component, as you can see in the figure here, of the overall adverse drug event rate. So an ADR is what a lot of people would call a side effect, and it's just any response to a drug which is noxious or unintended. And when we think about ADRs, we're usually talking about drugs taken as prescribed at typical doses, and still people are having these side effects. So that's where the star is in this ADR circle. And that's where we think that there's a role for pharmacogenetics testing in preventing these kind of side effects by identifying who's going to respond or who's going to be more likely to have an adverse reaction, and where we might be able to pick a different drug or dose. And this slide really just outlines my interest in pharmacogenomics and why I think it's so important to understand all of the drivers of medication response. In the United States, we fill more than 4 billion prescriptions a year, and response rates vary a lot. So one of the biggest challenges is diversity in drug response. Adverse drug events are a huge problem. Billions of or hundreds of millions of dollars a year spent on correcting and managing adverse drug events. One of the leading causes of death, we have some older data from the FDA that has adverse drug events ranked as the 4th leading cause of death here in the US, but we also have emerging data showing that it may actually be even higher than that. This graph is data taken from the US Food and Drug Administration adverse event reporting system. And as you can see, there's more and more reports every year. And even these massive amounts of reports that do come in are believed to be a substantial underestimate because of the lack of reporting and because adverse drug events are often missed altogether, in part because we don't have systematic processes in place to identify them, and because going in and actually reporting them can be very arduous and it's not required. And because it's so time consuming, people may not take that extra step of reporting events when they do occur. So not only does PGx play a role in potentially averting adverse events, it can also assist in helping us prevent and predict the efficacy of medications, essentially personalizing medicine. So this figure is taken from Nature in 2015. These were the top 10 highest grossing drugs in the United States, and it shows efficacy based on the reported number needed to treat for each drug. And if you recall, the number needed to treat, it's abbreviated NNT. It tells us how many patients need to receive a drug before we find just one patient who benefits. So here, the blue figures have the therapeutic outcome or prevention of the negative outcome. The red figures fail to respond to the example medication. So if you look at some of these, a lot of these are common ones that we still use all the time, aripiprazole, esomeprazole, rosuvastatin, some also specialty medications as well. But even so with N and T, the lower the number, the better. So with these top 10 highly utilized, expensive, often medications, at best case scenario here is showing 1 in 4 patients will actually have the therapeutic effect. So then there's this question of risk versus benefit. Every time we administer a medication to a patient, we ask ourselves, does the benefit outweigh the risk? If the benefit is 0 in that patient, then the risk always outweighs the benefit. That patient is exposed unnecessarily to harm. So if we could better understand preemptively how well a patient may respond to a medication, would these numbers still be the same? Or could we narrow down the patient pool to the group that's most likely to benefit, least likely to be harmed? And could we select a better drug for them or better understand what the optimal dose for that patient would be? And so this is just a brief history of some of the early milestones in the evolution of pharmacogenetics testing landscape. So in 2003, that's when we had the completion of the Human Genome Project. Just 1 year later, in 2004, was the first FDA approval for a pharmacogenetics test. In 2009, we had the formation and the first guidelines from the Clinical Pharmacogenetics Implementation Consortium, and Medicare, which is a major payer, national payer organization in the US that's offered to our members who are and people who are 65 years and older. They started covering the cost of the testing. That was in 2009. In 2012, that's when we started to have these unique CPT codes, which are ways that we can document the testing assigned for pharmacogenetics testing. So it made it easier to get the test reimbursed and covered by the insurance companies. So while PGx is a newer field in healthcare, one point I just want to emphasize is the extent to which new drugs are becoming more targeted and leveraging specific biomarkers to guide prescribing. So here we have on the screen a 2020 report from the Personalized Medicine Coalition, where you can see that personalized medicines accounted for at least 1 of every 4 new drugs that the FDA has approved in the past 6 years. So here they're defining personalized medicines as any biomarker related information in the drug label and genetics information referenced in the drug label itself. So to really emphasize this growth, remember that PGx began in 2003 with the completion of the Human Genome Project. That's when we first were able to start thinking about using genomics information to guide medication management. And with this report, you can see in 2005, we saw 1 in 20 new drugs with biomarker information to now more than 1 in 3 drugs containing genetic information somewhere in the drug label. And the changing landscape with drug development increases complexity in terms of how we explain a diagnosis and what the treatment options are. Product descriptions often include references to specific biological markers to help guide decision-making, and thus increasing the need for both patients and providers to understand how genetics affects health to help navigate the different treatment options. And pharmacogenomics is an integral part of the drug development process. This table is highlighting the number of biomarkers across the different therapeutic areas. So you can see there are a lot in oncology, where often we may be looking at novel therapeutics that can selectively attack cancer cells that express those markers. That's where we may be talking about some extremely high cost targeted therapeutics. On the other hand, there are even more non-oncology biomarkers across different therapeutic areas, where for the most part, we're talking about drug metabolism, and we really just want to test for genes that we know have a role in processing that medication to know if we should select a different drug or an alternate agent. And sometimes we may be choosing between 2 relatively low-cost generic medications, but in preemptively understanding how a patient might process that medication, we could possibly avoid really expensive adverse events and hospitalizations and a lot of downstream morbidity and costs related to that. So it's important to understand that the report back that you get with the patients genotype, phenotype, and maybe some sort of guidance on how to use that information based on what medications they may be taking. And some of you may have seen how those reports look, but there is a substantial amount of complexity that's involved in generating the information that's presented on those reports. So I wanted to highlight a few key concepts here, and this was a figure that was put together by the STRIPE Study Design Task Force, and they're preparing a framework for study design suggestions to help improve the clinical utility of the results. So a couple key things here. You have analytical validity, and that is talking about the accuracy and reliability of the genetic testing itself. So it's addressing the question, is the test accurately detecting genetic variants that it's supposed to detect, and how efficient is it at doing that? That's the analytical validity. And essentially, it ensures that the testing process is robust and consistent across different labs and different technologies. Clinical validity, on the other hand, focuses on whether the identified genetic variants have demonstrated association with a specific drug responses or clinical outcomes. So does having certain genetic variant truly influence how a patient responds to a particular drug? This concept bridges the gap between the genetic information and its actual impact on patient care. Clinical utility takes us a step further. It assesses whether using genetic information from testing leads to improved patient outcomes. The central question here is, does incorporating genetic data into clinical decision-making result in better treatment choices, reduced adverse effects, or improved therapeutic efficacy? And the process of establishing and assessing evidence to support the relationships between genetic variations and drug responses can vary. This variability ultimately influences the information contained in the test reports. And then these reports are then utilized by healthcare providers to make decisions at the point of care, directly impacting the treatment choices provided to the patients. And the complexity that exists in this process requires standards to ensure the quality of PGx care that we provide to our patients. So the U.S. Food and Drug Administration set a strategic priority to participate in 10 collaborative communities for 10 different medical devices. And a collaborative community is a framework whereby stakeholders in a medical device ecosystem can come together to better break down what the different challenges are and work together on solutions that would be feasible and beneficial for stakeholders across different areas of the ecosystem. So we submitted a charter to establish a collaborative community for pharmacogenetics testing in 2020. We call it STRIPE. It stands for Standardizing Laboratory Practices in Pharmacogenomics. And the impetus for forming the community was really what I just kind of described with the variation and the factors that lead to the information that's populated on the actual lab report that goes back to the provider, and all of the different variation that you may see across either different laboratories, technologies, interpretation from providers. So those are all kind of ongoing challenges that we've been working to resolve. And in the medical device ecosystem, collaborative communities bring stakeholders together to achieve common outcomes, solve shared challenges, and leverage collective opportunities. And so in addition to FDA has two centers that participate in the STRIPE initiative. One's the Center for Devices and Radiological Health, and the other is CEDAR, the Center for Drug Evaluation and Research, that also participates in STRIPE through a separate mechanism called public-private partnership. So the goal is that we can work together to develop frameworks, recommendations, that could potentially be adopted by stakeholders across different groups, including FDA, payer organizations, and clinical groups. And if you take a step back and think about the life cycle of a PGx test, there really are a lot of stakeholders involved. So starting from the point of the provider ordering the test, the patient may then, if the kit's going to be mailed to the patient, they may receive the kit. which lab is sending the kit, which genes and variants were included on that actual panel can be different across different labs. And I think there's been a lot of research to show different genes and which variants were included across different laboratories. And there were no two labs that really had the same panel, even if you're looking at the same gene in a lot of cases. So patient returns a sample that goes to the laboratory for testing. There may be different platforms or technologies that are used to analyze that specific patient sample. And then there's a report that comes back. And there may be different information that's included on that. There may be different guidance included on that, depending on how people are interpreting the evidence. And that may then go back into the electronic health record and kind of a clinical decision support system to be more enduring. And then the healthcare professional will review the results with the patient and make a decision based on what that report said. So just in that one test, from the point of ordering to the point of results, there are a lot of different stakeholders involved: payers, healthcare systems, different regulatory groups. Often we're using resources that curate some of these drug and gene associations, and then a lot of the major stakeholder groups, as well as the ongoing research to identify new gene and drug associations and continue to advance practice. So one of the cornerstones to the collaborative framework is that members do not only represent themselves, they also agree to serve as a liaison between Stripe and the organizations they represent through their participation. So we have over 150 organizations that participate in the Stripe collaborative community. And you can see on this double donut figure here some of those groups as well as the sectors that they represent. So we have members across 15 different healthcare sectors. So things like biotech companies, diagnostic companies, industry associations, research tools companies. So a lot of different people participate and represent their organizations through their participation. So for anyone that is interested in getting involved in some of the policy, the solution generating, you can find more information at stopadr.org/Stripe. There's no cost to join, and we meet quarterly with all members, as well as make opportunities to get involved with the different committees available. And one of the biggest challenges to PGx testing is patient access and whether or not insurance will cover the cost of the testing. Since payers often are looking to clinical societies and the practice guidelines to inform which products or services they'll cover, we looked at the practice guidelines. We looked at dozens and dozens of practice guidelines across therapeutic areas to identify if and in what circumstances PGx testing was recommended. And what we found was a lot of inconsistencies. Most guidelines either do not mention or state that they recommend PGx testing. There were a few exceptions listed here where testing typically was recommended for specific drug gene pairs, but it's generally not clear what evidence was used to make those recommendations. So a major question we have is around the evidence evaluation process that societies are using to assess that principle of clinical utility. So that's a little background on the landscape, and now I want to share a patient case from the clinic. This patient was a 52-year-old male. He presented to the clinic for polypharmacy management. We collected a cheek swab for him during the first visit. And between the time that we tested him and the time of his follow-up visit where we reviewed the results, and that's typically about 1 month where they'll come in for the follow-up, he already had a scheduled paniculectomy, which is considered a low-risk surgery. And basically what they do is it's in the setting of rapid weight loss where there may be extra skin. The paniculectomy is where they'll go in and they'll just remove the extra skin. It's a day surgery and it's again considered low risk. However, when he came for his follow-up visit to our clinic, This had happened, a couple weeks prior, and he was telling us what happened. And essentially, the day following the surgery, he was admitted to the hospital with severe bleeding. Medical history included post-traumatic stress disorder, depression, anxiety, hyperlipidemia, and radiculopathy. Patient reported becoming extremely hypotensive with a blood pressure of 60/40 and sudden loss of vision. They did a CT scan in the emergency room to see if maybe there was a nick on an artery during the surgery. However, no direct bleeding source was identified. The patient spent 4 days in the hospital and received 3 units of packed red blood cells. During this time, hemoglobin dropped from 16.7 at baseline to 8.4. So a very severe, near fatal case of bleeding with no surgical errors identified. His home medications included Tylenol with codeine, aripiprazole, cyclobenzaprine, fluoxetine, gabapentin, hydroxyzine, simvastatin, calcium with D, multivitamin, and super B complex. So we'll ask you the same question that the patient asked us. And the question was, could any of my meds have caused this? So I'll give everyone a quick minute here to weigh in. Let me activate the question really quick. All right, so you can, among the medications that this patient was taking, you can select one, more than one, or no medications that you think may have caused or contributing the extreme bleeding that this patient experienced after a relatively low risk surgical procedure. I'll give everyone a minute to think about that and add their response in. All right, I see one response. I'm looking for 12 responses. You can scan the QR code or type in this. Put this in the chat. All right, let's see what we came up with. All right, cool. So we had one brave respondent who seems like they remembered that fluoxetine, in addition to blocking serotonin reuptake in the neuronal synapses, can also block serotonin reuptake in platelets. So selective serotonin reuptake inhibitors can impair platelet function. Platelets store serotonin, which helps them aggregate and constrict blood vessels to stop bleeding. And SSRIs prevent platelets from taking up serotonin, which can lead to a depletion of serotonin and an increased risk of bleeding. So the report that, and we did publish this case, this is a figure taken from the manuscript. And this is a snapshot of some of the patient's pharmacogenetics results. So in our clinic, we run a 64 gene panel. Several of the genes are that we happen to test for this individual are known to be associated with SSRIs. And some of those genes are listed here, as well as the description of the genes and what this person's specific findings were. The major finding here is that the patient was a cytochrome 2D6 intermediate metabolizer, meaning that he metabolizes the S enantiomer of fluoxetine more slowly, and that can lead to increased drug levels in the blood. And the effect of bleeding is known to be dose dependent. He was also a cytochrome 2C19 rapid metabolizer, which can lead to increased conversion of fluoxetine to norfluoxetine, and norfluoxetine is also an is also active and contributes to the serotonin reuptake inhibition, so potentially additive effect on bleeding risk. And so this case just illustrates one example of how PGx information can be helpful to better understand the full clinical picture. So, and this patient was on multiple medications, and that's kind of the types of patients that we manage in the clinic are often polypharmacy patients. So usually taking 5 or more medications. Some of the people that come into the clinic are taking upwards of 25 to 30 medications, and it's been well established that drugs can interact with each other through various mechanisms. It's also known that drugs can interact with DNA by inducing or inhibiting the production of various enzymes or by disabling those enzymes once they've already been produced. What hasn't been well established is the degree to which this is true, in which clinical circumstances, and in the consideration of the nearly innumerable combinations of medications that a given patient could be taking at any point in time. So in 2021, we launched the Interprofessional Pharmacogenomics Clinic. It's a referral-based service with a 2-visit workflow. During the first visit, we use different questionnaires to identify any symptoms or issues and complete a detailed medication history. We also collect a sample for genotyping. And we also, originally when we launched this, it was as a research pilot. We were running a clinical PK to look at the drug levels to see if it kind of matched what we expected based on the PGx. And all of this goes back to inform a comprehensive medication management report that is returned to the referring physician. So the team at A&M developed a tool called the Clinical Semantic Network that was taking information from the electronic medical record and running some additional analyses to better understand the interplay between drugs, genes, and other clinical factors. So we're now building a comprehensive medication management dashboard to help provide decision support and pull in all of the relevant drug-specific information. In addition, we're building out a research registry and biobank. So there's a separate consenting process. You can see in box number 5 here for patients that elect to have their samples included in the research registry. And here you can see some of the dashboards from the Clinical Semantic Network, which is an electronic health record in its own right that was developed specifically for IPGx and can pull in clinical data from the patient's medical record. On the left side, you can see what we call the side effect profile. And this is showing the most common side effects and the severity of those side effects. And we can also see which symptoms the patient is actually experiencing. So this blue bar down the side, the stars are indicating which symptoms the patients are having. And if you look at even this first one with the example of nausea, you can see that a lot of the medications, almost all of the ones that this test patient were taking, can cause nausea. So it just gives us a little bit of a window into in what ways some of these medications could be contributing to the complaints that the patient's having. And then we also have on the right here a pathway summary to see which medications are inducing or inhibiting various enzymatic pathways. And even before we get the PGx results, just by adding in the medication list, we can see which drugs are working through different enzymatic pathways like the cytochrome enzymes. And then once we get the PGx information, we can layer that in on top. If they're a poor or rapid metabolizer, that might affect the degree to which those enzymes are quote unquote overloaded. So, and then we combine that information with existing knowledge of the patient journey. So that's a little bit about the service that we developed. Did want to mention I am on LinkedIn, so feel free to connect. Would love to chat with anyone if you have any additional questions or thoughts after the webinar. And with that, I'll turn it over to my friend and colleague, Dr. Bader Al-Ghamdi.
Good afternoon, everyone. So my name is Badr Al-Ghamdi, and currently I'm clinical assistant professor at Salbah University, College of Pharmacy. And at that time, actually, so today I'm going to be like sharing with you a real life clinical pharmacogenomic workflow that takes place in a behavioral health clinic. We did this project during my training at Texas A&M Family Care Clinic with Dr. Sarah Rogers. And okay, so let's start by seeing what is the problem that we are solving. Basically, if we are talking about behavioral health, I think the major issue that we face in behavioral health is trial and error. So usually patients try multiple drugs before they reach to the right treatment. The reason is that each drug is metabolized by enzymes, different enzymes like CYP2D6 or CYP2C19, and this might affect basically either the efficacy and safety of the drug. So that's a major issue, and I think the answer to that issue is basically pharmacogenomic can help us with solving that problem. Another issue is that actually antidepressant response rate is low, so we need to see what is the reason for that. So pharmacogenomic also help us with answering this question. So that's the main issue that's with the behavioral health. And for our setting that the project takes place in, the clinic actually wasn't major teaching medical facility. It was community-based with limited resources. And it was serving basically underserved people. So people with low income usually come to the clinic, patient with most of the time Medicaid insurance. The team were like physicians. There was psychiatrists who run this behavioral health clinic and lead the clinic, along with the physician, with the psychiatric resident, with also medical residents. And before we run this project, we have been added to the team so we can learn more about their workflow and all of that. So they add Dr. Rogers and me. We're being added to that team. And so for that, I think like in terms of like the clinic and the patient base and also the team, I think the goal was to find a simple and scalable project to run the pharmacogenomic without interrupting the whole team or like the whole workflow for the team. So how we made it work? So I think so we take it easy. We take it first. What we did is that we did the readiness assessment project with a survey. So we surveyed all of the clinic team with some questions that need to be answered, like for example, what is the concerns that they have for running this project, if they have any interest in running this project at all, also like if they agree if this pharmacogenomic would improve the care, if they need any training in certain area. So once we collected all of these answers, we launched the phase 2, which is start implementing the project. We find that we can do like a reactive and preemptive pharmacogenomic testing, and also the vendor help us with mailing the kit or the buccal swab to the patient home. So we can either mail it or we can run it at the clinic as well. We can do it at the clinic. So that was easy step for taking the test. Also, in terms of reviewing the results, we were the one who the first reviewing the results, and then also later on discuss it with the whole team in an interprofessional kind of meeting. And the recommendation later on, we do it in the different meeting, and then we come up with the plan for the patient. So what made it work? I think it's not just the test, but also the people. So the people we work with, the psychiatrist and the physician and the whole behavioral health care team helped us running this project very easy. And from us for the effort and also the clear workflow that we provide to them, we made sure that the workflow that we are implementing is not interrupting their workflow. They have a lot of work to do, and something like that, adding service like that, it takes time and effort, and we don't want to kind of interrupt their workflow while improving the care of the patient as well. The patient is, the test is friendly, and it's non-invasive. As I said, it's just a buccal swab. And also, when we did this test, we respected for sure the patient autonomy. So the pre-test counseling were very clear, and I think Dr. Rogers made a lot of good job in term of like making all of the complex, terminology easy to the patient. And yeah, so we made sure that the patients opt out at any point, and we make sure that the main thing is that we tell the patient is this test is only to kind of make us choose the right medication. It's not like to test for anything else. It's just for making sure that your medication is the best fit for your for the disease that you have. So this is the simplified version of the workflow that we did. The left side is the existing behavioral healthcare workflow. So we understand that how they work, and we tried not to or we tried to build our workflow to make sure that it's gonna be like not interrupting and it's easy to fit in. So the first thing we did is that we identify the patient, and we did the eligibility review, and that job of take place 1 week or 2 weeks before even the patient came to the visit. So we know the patients, and if he or she could fit for the test. Once we do that, we discuss it with I discuss it with Dr. Rogers and with the whole team, and to see if we can call the patient, maybe do some kind of confirmation, do the counseling, and also do the informed consent if the patient agreed to take the test. Once we do that, we kind of wait for the patient to come to the clinic to do the test. If we couldn't do that, then we send it to the patient, and we send the test to the patient's home, and we kind of done the test. It takes usually 7 days, 5 to 7 days for the results to come up to the website they have, and also they email it to us. The goal was actually to basically integrate it into the EHR, but this is totally different project, and it's need a lot of resources and time to do that. After we do that, the patient usually come within 1 month for the follow-up visit, and by that time we have already the results in, and we usually discuss it beforehand with the team and with the patient later on once the patient come. And we can also follow up with the patient either through the phone and also with different visits that the patient have. So the process is not we are not adding any extra visit or anything. We just kind of fit all of the talk within the visits that the patient already have or gonna have. These are eligibility criteria for our service. So the patient's basically first seen for the behavioral health disorder and considering psychopharmacological treatment. This is the main headline. Usually we are we haven't done a lot of preemptive testing, but we did a lot of reactive testing. I think preemptive testing, it's gonna be it's visible, but it's hard to select the patients that they need to be tested. That's the process. And then also the patient need to be consenting for testing. I think what didn't work for our project is that the HR integration. And I think this is just because the time limit that we have. And I think once you start the project, you can start small without EHR integration. The report that you're gonna have from the vendor, it's kind of a lot, like around 200 pages, but it's simple and you can read it easily, and it's very clear to kind of get what like the kind of like the clinical implication from it. Also, no clinical outcome measured, and that's was our plan, is to kind of run some kind of retrospective study out of the data that we already collected. Hoping that we do that some kind of work in the future, either in the same clinic or different clinic as well. But this is very important because I think all of the data we have mainly is from clinical trials, and we would love to see more like real life data coming out. So we need more project and we need more research around it. So that's important. So let's bring this to life with one example that we have. So this patient, he's 24 years old. He came with severe panic disorder. As you see, he failed a lot of medications. First start with paroxetine, and as you see, the patient has sedation at low dose, meaning that the medication accumulated into the body, into the blood without being cleared out. So we suspected something like, poor metabolization. Fluoxetine is the same. The patient has GI symptoms. So usually the patient also like have some kind of accumulation of fluoxetine in his body. So that's what might cause the symptoms, the GI symptoms. Phenylafaxine is also has the same problem. It's adverse event, but also it's not showing any effect. So we also see worsening anxiety, and that the reason maybe because of the phenylafaxine is a broad drug and need to be converted to the active drug, which is this phenylafaxine. So in that case, the CYP2D6 that need to be kind of work to convert the drug is not working well here. So that's why we see adverse effect from the medication itself, which is phenylafaxine, and also lack of effect from lack of converting the drug to this phenylafaxine. So I think that's the pharmacogenomic test would be a good fit for this patient. We done the test, and the test shows poor metabolization. So the psychiatrist choose to use monoamine oxidase inhibitor, and he's done very well with it. If this patient has preemptive testing, I think we would save a lot of time, a lot of effort in order to come up with the right medication. So imagine like each drug has at least 6 weeks in order to show the effect. So like the patient lost a lot of time trying a lot of medications without any effect and any like response. This is more information. I think for each test, the pre-test counseling and post-test counseling is very important, and how to interpret your test result and how to make it a patient-friendly, the terminology easy to the patients. It's very important as well. The panel that we used basically test for the main gene, the CYP2D6 and CYP2C19, and also like the other drug transport gene, ABCB1, and the drug target gene. So now the variation this is for the headline, I mean for the genes that we tested for. And as Dr. Rogers says, different labs may test for different variations in terms of like inside these genes. So, but as long as the patient has at least, tested for these two main genes, that's something that we can start with it at least. So this model shows? I think one of the things that's I find it important is that start wherever, like without even like you have the perfect setup. You don't need to have the perfect setup in order to start any implementation work. You can start small, even if you have tested one patient like for 6 months. That's enough to kind of like one patient matter at least, and you can grow with time, with experience. But I think it's time to start a real life implementation work, not just the research work. I can see the effect, not just even if the test doesn't give you any kind of important results, but you would give extra care for the patients, the clinical service that you do, the medication reconciliation, the service from the pharmacist would make difference to the patient. So adding service like that would be a great addition to the patient care, basically. In my work right now, I'm hoping to kind of create or scale this model to the clinic that we have. I'm starting by kind of like doing some kind of presentations and work to the physician so he can promote awareness about this pharmacogenomic, because maybe we are pharmacists more kind of having more knowledge about it, but the physician need to be more like aware as well. So I think that's something they can start with, either like doing some educational presentation, or survey or something like that, something to start with, and then you can move up to the next step. Other thing that's very important is to create some kind of local pharmacogenomic training module. I think the ACHB is very great, and I think it's enough to start or to give you the baseline for how to, like for the clinician, but also starting some local pharmacogenomic training is very important within your country, because each country has different legal and other policies regarding this pharmacogenomic testing. Partnership with the vendors or with the third party is very important as well. They can help with AHR integration, also like automated result handling. Also, all of these information would be helpful to make the life easy for the pharmacist who kind of read the results. Yeah, these are the main. So I think the final message or final takeaway from this presentation is that launching something like that is not only feasible but also welcomed. So from your side, you need just to think about thoughtful workflow designs, something that can help the physician and like the whole clinic team to run this test without any and also do the educational material and all of that without interruption the whole clinic team. Also building trust between you or the pharmacist and the healthcare provider is very important in order to run something like that. I still think that the pharmacists are the leader in terms of the implementations. Nobody can be able to implement the pharmacogenomic in their service without the help of the pharmacist or clinical pharmacist. And definitely the patient-centered delivery, the patient are the main part here. So explaining the test, explaining if it's like the pre-test counseling, the post-test counseling, all of these are matter to the patient. So the patient has to be included in the decision. And here is the QR code for the article we published, in order if you want to like read it and know more about the work that we did. And happy to receive the questions discussion. Thank you.
Thank you both for such an exciting talk and all your great insights and different experiences in implementing this. We do have quite a bit of questions, so let me just kind of kick it off with And I think the nice thing is, and I completely agree with you that pharmacists have to lead these efforts. There have been many, many write-ups in the literature. There's evidence showing that I don't know if anybody wants to do this, right? And it's a complex healthcare system, and somebody needs to take ownership of it. And pharmacists seem to be the correct team member to kind of move this forward and are dedicated to it because, as you see, that there's a lot of stakeholders, and we tend to sit kind of in the center of it all. And so with that, this question's for Sarah, but I would like to hear from both of you. Considering that there are so many stakeholders, if you could design an ideal framework of pharmacogenomics integration in clinical practice, what technologies, what innovation would you use or approach you would use to enhance patient engagement and adherence? Because that is one of the most important components of this, right? Because you want to get the patients kind of be the advocate for the patients and also empower them to be the advocate. So if you want to start, Sarah, and then we'll move over to Dr.
Sure.
Ramsey.
Yeah, I think that's a fantastic question. And it's a critical one because if we truly want pharmacogenomics to deliver on its promise of safer and more effective care, like you said, Charmaine, we have to kind of engage the patient. So for me, as I think through what an ideal framework for PGx integration might be, I feel like it has to go beyond just getting the results into the chart, which is still already a challenge. So getting the results in the chart, but also needs to actively engage patients and support real-world decision-making. So I kind of think of three key innovations or tools that come to mind. The first is user-friendly digital tools. So thinking about things like mobile apps or patient portals that can translate genetic results into plain language, explain how medications are effective, and prompt questions for the care team in between visits to kind of help empower the patient to make better decisions. Because we go through during our second visit a lot of that consultation, but some of this stuff can be very foreign for people. So giving them ways to be able to better digest that information and refer back to it, I think is really huge. And we have an external collaborator that we're working with right now that is going to be doing some QR codes and through an app. So we're going to be piloting that piece of it pretty soon. Also clinical decision support that follows the patient. So on the one hand, we do have a new integration where there are going to be alerts that fire if the patient is going to be prescribed a medication where there is a relevant gene-drug interaction, and it provides more information at the point of prescribing. But I think we could go even beyond that to kind of more portable standards-based solutions. We've talked about some of the technology interoperability, things like fire genomics, just to make sure that the information is visible and actionable across settings, and especially for complex patients who see multiple providers. And then pharmacogenomics informed adherence strategies is the third one I think about. There is different data and studies that have shown that even the act of getting the PGx testing performed helps improve medication adherence, because people feel like that information and the decision that was made, even if it was going to be the same decision as before the testing, is personalized for them. So they have more I guess, belief that that medication is going to work for them. So they're more likely to take it consistently. And if there were kind of like this ideal framework of taking those results and translating those into medication reminders, digital pill boxes with tailored messaging, I think that could go a long way. So those are a few things that came to mind. I don't know if you have anything to add, Bader.
I don't have anything to add. I echo all of what you're saying. So,
All right. Let's see. So we have another question. It's about eligibility. So my question is the eligibility criteria and framework. We're planning to launch a pharmacogenomic testing service for pediatric patients, perhaps for limited specialized indication like oncology and transplant. From your experience, do you have any recommendation of an initial plan? I think the person asking this might want to get in touch with you directly, but if you want to kind of give an overview or a quick response, and then I think this may require a little bit of a collaboration and maybe a direct conversation. So Badr, do you wanna kick it off, or Sarah?
I don't have an experience with oncology and pediatrics, so I'm not gonna be able to answer.
Yeah, well, on the flip side of that, though, I think Batter just kind of outlined the plan. So I think the first step is really talking to your providers, seeing where their pain points are, which patients are more difficult to manage, why are they more difficult to manage, what drugs are they prescribing, which of the drugs that they're prescribing have those gene drug associations and already have kind of a CPIC guideline or something like that. And then, as I kind of showed with all the different biomarkers and drug labels, there are, a lot of medications in the oncology space and in the transplant space. I think one of the bigger challenges in the pediatric population is that the PGx results may not be truly reflective of where they are at their enzymatic development. So that's just one consideration. And there are going to be different nuances to that, but I love that you've kind of identified what that patient population is. And I think it's just that going through that process of seeking feedback, identifying where to start. Maybe it's just one drug that you want to start with, trust a few patients and learn from that and get feedback from the team on, how they want the recommendations, what format, some of those logistical things. I think that piece of it will go a long way.
Yeah, I completely agree. I think the first step is kind of, sometimes implementation of pharmacogenomics can be overwhelming. So starting small with one, getting that experience, and then, scaling that model to other drugs or other therapeutic areas is a good approach. The person asking the question, you've added one more layer of a complexity, which is the pediatric population, which we know, is kind of a really wide cohort. So keep that really in mind, that, which pediatric population you're focusing on, because that will determine, your actions or your guidance to prescribers on sort of what they should do about the results, because that's the biggest question that physicians will have that are prescribing, at least that, from my experience, and I'm sure Sarah and Badr have also experienced this, is that this is great information, I want it, but what do I do about it, right? How do I act on it? So you want to just kind of keep that in mind as you're planning for that. Another question is about, this is a hypothetical, so I'm curious to what you will say. If tomorrow you could legally prescribe based on genomics alone, no insurance barriers, no clinical inertia, what rule of traditional prescribing would you immediately break?
Batter, I know you're a rule breaker, so I'm sure you have a lot of thoughts on this question. I'm just kidding. So for me, I think if I could break any traditional prescribing rule tomorrow with the power of genomics without any barriers or pushback, I would break the silent acceptance of prescribing cascades. And that may just be based on my experience in managing polypharmacy patients who are on a lot of different medications. But we've kind of normalized this pattern where side effects get treated with more medications instead of questioning the root cause. And genomics gives us an opportunity to kind of stop the cycle and recognize when an adverse drug reaction may be driven by the patient's genetic makeup, and just kind of adjust that original medication rather than layering on new ones. So I'd break the rule that says just, if a patient comes in, they're getting a new prescription, and replace it with that precision medicine approach to prevent prescribing cascades from starting in the first place.
That would be a world we all look forward to. If this is for Dr. Badr, if a patient's pharmacogenomics profile predicts poor response for first-line psychiatric treatment, do we have an ethical duty to override clinical guidance, even if the system isn't ready to support it? So since you're in that space, I'm curious to hear what your thoughts are.
I think that would be like a team-based decision making. So I think we are ethically obligated to use all of the available data that we have. So we are adding one data to the decision. So we have to kind of take it into the account. But that would be, I think, sharing the patient as well, sharing the patient into the decision, telling them all of the information that we have about the test, and that you have like poor, like for example, if the patient is poor metabolizers, then tell the patient this drug might not work with you. All of the data that we have, and sharing this with the whole team, and do it as a team decision. Like kind of team-based decision. But I think as far as for now, I don't think we have any ethical to override because if in the guideline is not like kind of we don't have, for example, clear guidelines that tell us to basically use this or like based on the results do this or do that. So I think that could be a team decision based, and sharing this information to the patient so the patient can be included into the decision as well. That's I think my answer to it, but it's hard question. It's a tough question. Yeah.
It is a tough question. Sarah, did you want to add anything to that?
Yeah, no, I totally agree with that perspective. And just to kind of echo the piece about the clinical practice guidelines, those guidelines are just reflecting whatever the evidence is and whatever flaws were in the different study designs that generated that evidence. And it's reflecting a population level approach. So there's always going to be nuances, and that's why they say practicing medicine is kind of an art, because there are so many different things that go into whether or not a patient is going to respond or if they're going to respond well to a different medication. And the other thing about the clinical practice guidelines is they're, typically just looking at a specific disease state. And when you layer in other conditions, other medications, it's not as clear and cut and dry as the practice guidelines may make it seem. So that's the reason why, if we have that additional information and we have some sort of kind of idea on how that might help us adjust their therapy, I think our obligation is to personalize it in all the ways that Badr was mentioning, talking to the patient, talking to the team, and then maybe even monitoring them more closely. But I think collaboratively we can get a plan in place to use that information, as long as there's no like contraindication or anything like that. I think we're good ethically.
Yeah, and I agree. I mean, I think people need to just kind of think of pharmacogenomics as not some like different type of information that's available for the patient. It's no different than, I always like to tell people this is one piece of the puzzle, right? So it's no different than getting the patient's lab, their other drugs, evaluating drug interactions, those kinds of things. So, just think of it as the kind of completing that whole picture and making your clinical assessment. And that will determine whether, what information you want to bring forth and how you want to make those decisions. It's not it's never black or white in medicine, right? I was in pediatrics, so it was always gray, and you just have to be okay with the gray and know that the interdisciplinary team is going to make the right decision with all the information. So while we would love for guidelines to tell us exactly like what steps to take, that's why the team is needed, right? That's why the interdisciplinary team is needed to do the full evaluation. So this is more of something I always think about when I'm reviewing any, PGx tests or information or talking to patients. And so I'm just curious, I think given the audience, they would be interested in hearing your responses. We know where PGx information currently falls short. It's not a diverse data set. It's not reflective of everyone's, it may not be reflective of everybody's results. So if you are reviewing it, how do you kind of incorporate that? Because I imagine as more and more education happens at the patient level and become more aware of it, these are questions we're going to have to answer. That are these guidelines reflective of the patient population that may be regional or local? And so how do you approach that response? And Dr. Alghamdi, you're in the Middle East region practicing. So are those questions you're getting from your patients? And if not, how do you anticipate addressing those concerns that patients may have?
Excuse me, could you repeat the concerns or the questions that like I
Yeah,
didn't.
so the concern being that the guidelines are established with the evidence that's out there, which may not be a diverse data set. So
Yeah.
how is that incorporated into the current
Yeah.
guidelines and kind of future strategy on that?
Yeah, so for me, like practicing here at my country, I'm still kind of like this is my like maybe around the third month. So I start since I started practicing, but I think and I always call for more data that is generated here in the Middle East. So all of these clinical trials that has been generated outside, I think we need similar studies that can be kind of reflected our patient profile. That's from our side as a researcher or as providers. So far, what we are doing is that we are taking what is available out there. So, um, is that good to do or not? That's what we have so far. But from our side, I think doing some research regarding whatever questions that we have, clinical questions that we have, is very important. Yeah, that's my answer to. Yeah.
Yeah, I'll agree with that. I think a lot of the work that we need to do is prospective. So, for example, when we look at papers that kind of, summarize a clinical trial, we often see, a cohort that if there's two cohorts, like an implementation cohort and a standard of care, you may see, some demographic information about, okay, well, there was this percentage of males and females in both cohorts, and trying to just show that the cohorts were similar in terms of their composition, ethnicities, things like that. But what I very rarely see, and I've never seen actually, is could we stratify, cohorts and show how many patients had this metabolizer status for the different enzymes that were involved? And is that kind of why we see more adverse events or something like that? So I think there's still innovations to be done in designing studies. The thing that I think is really important and something that we could do now in terms of regionally where we practice, even in the States, some cities have different um, demographic prevalence across the US as well. So you have to think a lot about which variants are most common in that patient population. So the panel selection is really important. We already know that a certain drug, say tramadol, is associated with a certain cytochrome enzyme and it's a prodrug and all of that, but there may be different variants or things that are more prevalent. So choosing that panel that's more reflective of your patient population is something we can do now. And I think Egypt has a really good model that they have done where they went out and basically sequenced everyone for the first year of implementation to see where the highest prevalence was, and that they designed a panel that was specifically reflective of their patient population. So thinking about things like that to really get it right for your region.
Yeah, that's very helpful information. I know we're getting close to the end of our time here, so really want to thank you both for all the information you've provided in the presentation. As we indicated, both of our speakers are on LinkedIn, so you can reach out to them. There's several organizations and resources available that we can either include in the chat here or share with the network. There's CPIC, PGRN, Stripe. Stripe is a very unique organization. I'm a part of it. It's a very active group, so I would encourage you to kind of look into it and consider joining, because the more representation there is in the organization, the better it is. And everybody on here is obviously interested in personalized medicine and implementing and moving forward pharmacogenomics. So just know that collaboration is the key in making all this happen. Although we're so far along, we're still kind of at the early stages in the clinical space and really learning quite a bit from each other. So I know everybody's always open to collaborating and sharing their experiences, so don't hesitate to reach out for those of you who are starting off. And I will turn it back over to Zaina to close out the session here.
Thank you, Sharmeen. Thank you, Dr. Sarah and Dr. Brother. This was a very an excellent session. So I want to take a moment to sincerely thank you thank our incredible speakers for their insightful and practical contributions today. Your responses also to the excellent questions from the audience really enriched the discussion and brought so much value to the session. And also, I want to thank our wonderful moderator. Thank you for guiding that conversation so smoothly and meaningfully. And of course, to all of you, our audience, your engagement and your thoughtful questions and presence truly made this very special webinar. We are so grateful to have such a passionate and curious community who are really passionate in pharmacogenomics and its implementation, and specifically in this region. Thank you once again, and we look forward to seeing you in our future IVPN Personalized Medicine events. And until then, take care and stay connected.
Thank you, everyone.
Thank you.
Thank you. Bye-bye.